The broadcast is now starting. All attendees are in listen-only mode.
From my little clipboard, the number 59, as well as the 59 over here, as well as the 59 coming out of my mouth. This is our 59th webinar of the academic year 2021-2022, and I'm really thrilled because there's only 3 left, which means by the end of next week I'm going to be extremely happy, simply because I'll have about a 3 or 4 month vacation. Who knows, maybe I'll have a permanent vacation. Also, we also mentioned this on our Facebook announcements as well. And those were the Eagles that opened it up this morning, and now it's officially 9 o'clock. Excuse me for a little bit of a hoarse throat. Maybe it'll clear up as I start talking. Okay, today's webinar will be first of a 2-part series on environmental and nutritional disease. So this will be ENVNUT1. And today is Tuesday. It's April 26th. We're near the end of the month already, and it's still damn cold in Chicago. That's why I still have this sweatshirt on. It's 9 o'clock in the morning. I did not really enjoy the last chapter we did, but somehow we made it pretty smoothly. This one I enjoy much more, partly because it's a whole series of things in general pathology that didn't quite fit in at the beginning, so we're going to deal with this concept of exposures and injuries and even some nutritional stuff. Another reason I like it is because the chapter was written by the man who also edited the entire Bible of Pathology, Robbins. That's my friend, Dr. Vinay Kumar. And it's very, very well done. Okay, what else do we want to say? I don't think we want to say anything. So how about if we forget the rest of the announcements, if there are any? I don't think there are. And let's start talking about environmental and nutritional diseases, part 1. So here we go. In the old days, which is probably when I studied pathology, but even way after that, we had this concept of toxicology. How do you deal with toxicology as a part of a pathology course? You know, there's so many things that are toxic, of course. We've already dealt with many of them at many levels, but think about it. Not only do you have toxic drugs, but you have toxic radiation, you have toxic injuries, you have toxic chemicals. But this whole thing can probably be summarized into one word, and I think it's a pretty appropriate word. It's called exposures. So besides being exposed to this thing we call the environment and all the possible diseases that we can get from it, we have the common exposures from the environment, perhaps the medicines we take, perhaps our occupation. There's going to be a whole list of things that we're talking about. And then I guess you could talk about the lack of a proper exposure, or perhaps too much of a proper exposure in nutrition and disease. So we'll be talking about probably a couple of the important vitamins and their lack of, or maybe even their excess of as well. Now, I thought I'd start out the whole show today with something that is very important, but not directly pertinent to what I just said. It's called occupational diseases, and this is primarily the United States and their classical number of reported cases, okay? And OSHA, the agency which is concerned with Occupational Safety Health Administration, keeps these numbers very, very good. And they don't change that much over the years. So by far, the most number of reported occupational diseases are trauma, or let's say minor injuries. There's another category here called physical injury, which is much more serious. But out of all these numbers, 500,000, more than half of them were just repeated trauma, cuts, burns, scrapes, bruises, contusions, blah, 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 64%. But then there's a lot of skin disorders because of coming into contact with things at the workplace. So that's the second biggest percentage. The rest of them are relatively small. Of course, lung conditions, fumes, industrial lung conditions is a good number. Significant physical injuries, not just minor injuries, is on the list as well as poisoning. You could have poisoning with respect to being on the job and exposed to something that's poisonous. And of course, not only do we have lung diseases in general, but the so-called dust lung disease, the pneumoconioses, the things you would expect perhaps coal miners to get in that general range. All the rest of them that you could imagine is only 12%. So we're really talking about all of the things at the workplace itself. You know, we'll be talking about other places like home, you know, where you can have an exposure resulting in a disease. But this is a very, very important thing, and you have to remember that the regular old repeated trauma is the lion's share of all of them. Now, when we're talking about an exposure, we're talking about an exposure to something that's toxic, okay? And I think this is a pretty logical diagram here, or a list, because if you are exposed to a very, very small amount of something, there will probably be no effect. So there's a threshold above which many people, most people, everybody, half the people will have some type of measurable effect, whether it's a lab effect or a clinical effect. Now, this toxic substance, and remember, it doesn't have to be a drug or a dust. It could be something even like trauma in a way. It could be anything, technically, even radiation, okay? It has to be absorbed at the portals of entry. It has to get into the body, either orally through ingestion, inhalation through the lungs, or through the skin. I really can't think of any other common way, can you? And then once this toxic substance is in the body, it gets metabolized. Now, it could be metabolized into something that's worse than what actually came into it. It could be metabolized into something that's not as toxic by a variety of methods we'll talk about. And then it could be excreted or not excreted, okay? Some things may be in our lungs forever, okay? And then you have a whole wide variety of the toxic effects. And they could be measured by a physical exam or lab tests or x-rays. Here, let's take a look at what we would call xenobiotic mechanisms. Now, a xenobiotic substance, here we're talking basically about chemicals now, and it's a substance which is not usually part or present in an organism, but comes in contact with it. That's the broadest definition. Well, when your body comes in contact with something that does not belong there in general, we're talking about basically drugs now or chemicals, the natural reaction is for the body to protect yourself from it. Now, because basically what it wants to protect it from is getting into the cell, it wants to make that substance less lipophilic. Why? Is because the cell is a lipophilic membrane and it wants to make it nonpolar or less lipophilic. Now, there's two ways of doing that. One of them is called a phase 1 reaction, and one of them is called a phase 2 reaction, but they're basically very, very similar in that they're taking this chemical substance and they're making it less lipophilic. Okay, well, one way to make a lipid less lipophilic is to add oxygen to it, eventually turn into something. And there is the cytochrome P45 monooxygenase system, which will oxidize it from its name one way or another, adding oxygen. Maybe some of these take away 2 hydrogens rather than adding oxygen. But that's one way of doing it. There's another monooxygenase system that does the same thing, and it's called the flavin containing system. And then there's regular old peroxidase, common enzyme, which basically is a hyperoxygen agent like peroxidized, okay? And that's another way of making it less lipophilic. Now, in the phase 2 reactions, it's basically a similar thing. It's the end result is to make it more polar, or let's say less lipophilic indirectly. But if you make something more polar, you add a polar substance to it, okay? Like glucuronide, okay? remember what happens with bilirubin in the liver. It becomes bilirubin glucuronide and indirectly becomes more polar. Another thing to add is a direct methyl group to make it more polar as well. So when you add this substance to a more polar substance, the whole thing becomes more polar. Another thing is glutathione conjugation, or what they might call glutathione reduction, in which you add this glutathione group. And here, if you just want to know what a glucuronide looks like for you chemistry buffs, it's basically a substance like this. If you want to see what glutathione looks like chemically, I put it up there for you as well. Okay, now let's get back to the whole big scheme of things now. You have an exposure to a substance, okay, and we can call it a xenobiotic substance. We could call it a substance that shouldn't be in your body, not necessarily toxic, but it doesn't belong there. That's the definition of a xenobiotic substance. It gets in through one of these three portals: mouth or ingestion, GI tract, inhalation, skin contact, and then once it's in the body, it distributes. Okay? Now, if it's easy for the body, it'll directly excrete it through the normal excretion mechanisms. GI, kidney, okay? However, it can become metabolized to be even more toxic. And the most notorious example of that are the tar compounds that are found in cigarettes. The tar compounds, okay, I don't know if there's a general family name for that, can become more carcinogenic after it's metabolized by the body. I bet you didn't know that. Or, obviously, ideally, it's metabolized to become less toxic, okay? And it's becoming less toxic. One way is by this methods that we talked about over here. And another way that it could be is conjugation products, okay? Conjugation is a function primarily of the liver. When you conjugate something, okay, let's see if we could get rid of this guys again. With this compound here, glucuronide, or other conjugation compounds, they become or can become less lipophilic, more polar, or let's say less toxic. Okay, well, once they are metabolized, they could actually become more toxic. See, this may not be a direct carcinogen. It could be a pro-carcinogen, but after it's metabolized, it would become a more deadly or promoter or a definite carcinogen. Now we have something that's distributed in the body, hasn't been excreted, it's been metabolized one way or another, and now it does its damage. It does damage to macromolecules, it does damage to nucleic acids, it does damage to proteins, to receptors. Okay, sometimes these things can be repaired. We talked about the so-called nucleic acid DNA repair genes and so forth, which hopefully are working. But at the very end, it has a toxic effect, or could be if it's not repaired or excreted early or metabolized to become less toxic or non-toxic. So now we have the toxic effects, the things we talked about: genetic damage, carcinogens, damage on the reproductive system, okay, damage to your immune system in general. So I really, really like this chart a lot, and that's basically the scheme of what can happen and does happen when we are exposed to toxic substances. And speaking of toxic, you've probably heard of, maybe you don't have one in your neighborhood, but you know, in the United States, again, we have toxic waste dumps. And I don't know if it's a big secret of everything that's stored over there, hopefully forever, hopefully to keep us from it. But I guess you could take chemicals, especially industrial chemicals. I guess I could rattle them off, or you could read them. Things like acetone, aldrin, dieldrin. These are all either carcinogenic or heavy metals or downright poisons. Barium, benzene, some of the things that are so important in industry, making good things for us, the chemicals involved themselves are very toxic. 2-butanone, cadmium, heavy level, carbon tetrachloride, an easy chemical to figure out. These are all basically industrial toxic substances. Chlordane, chloroform, chromium, another heavy metal, and of course cyanide, probably one of the worst ones of all. Here we go. We could go backwards here. Zinc. Everybody is dying to take zinc nowadays because we heard it's so good with COVID, especially if you use it with vitamin D and vitamin. Well, zinc by itself in very tiny amounts is very, very good for your immune system. But in general, it's a metal that is toxic. Vinyl chloride, carcinogen. Most of these are either toxins with known effects or carcinogens. Tetrachloroethylene, polychlorinated biphenyls, pentachlorophenol, nickel. Okay, probably mercury, lead, another heavy metal, methylene dioxide. Okay, these are all things. DDT at the top of the list. It wasn't that many years ago when everybody thought DDT was so great because it killed all those bugs. It probably killed just as many people as it did bugs. Okay, so these are the contents, common contents. You probably recognize most of them already of your so-called toxic waste dumps. So here we are with a response, a clinical response versus a dose of a toxin. And we mentioned this before briefly, but below the threshold dose, which you can see here is the TH, there is no clinical response. There's nothing wrong with the lab test. There's nothing wrong with the patient. There's no symptom. So this is a sub-threshold response. But then as you go up significantly, let's say tenfold, you start to get some people, but maybe less than half, with some types of clinical response. At the point of the dose in which 50% of the people have the predicted or usual response, you can call that the 50% level. It means half of your controls have responded. And of course, as you increase the dose, it's going to approach 100, but of course it can't go above 100. So the whole thing is basically a sigmoidal or S-shaped kind of a curve. Okay, so let's start about probably the single most common with alcohol toxic substance that men have decided to expose themselves to, okay? And that is tobacco. And once again, we're talking about the United States. People all over the world smoke. Some countries more than us, believe it or not. This chart is not too old, but let's say as a general round number, about 500,000 people in the United States die before they should, normally, their predicted lifespan because of tobacco. In fact, here I put it, by far, it is the most preventable cause of death in the United States. Of course, everybody knows its role with cancer, not just lung cancer, and not just all the different types of lung cancer, but also cancers of many other major systems, like bladder, for example, like pancreas. It has a whopping effect, horrible effect on cardiovascular disease. Okay? It's something that basically disrupts, damages endothelium, which is the beginning of cardiovascular disease. This big, big, big number one killer called atherosclerosis. Respiratory disease, specifically chronic respiratory disease, specifically what we might call emphysema. If you are ever confronted with an emphysema patient or chronic obstructive pulmonary disease, which we talked about extensively, almost certainly this is going to be in a long-term smoker. Whether you encounter that patient in your office or in the hospital or on an exam, like a step 1 exam. And of course, the same damage that it's wreaking to the blood vessels does not exclude the brain, so strokes as well. And I don't know, even if this is only a few years old, I imagine that this number now is much, much higher. But the thing you should remember, if you were wanted to estimate the amount of cost on health care, tobacco-related illnesses, I'm sure I should probably update this. It's 150 billion a few years ago. It could very easily be, even with inflation, twice as much. So, but it's about the same as alcohol-related health costs too. Okay, here, I'll tell you this now because we're going to get to alcohol in a minute, but the economic impact of tobacco toxicity is about the same as the economic impact of alcohol toxicity. Now, in terms of deaths, however, there are more people dying of tobacco-related illnesses prematurely than alcohol. So if that number is 500,000 for tobacco, for alcohol it could be maybe only like a couple 100,000, okay? But the economic costs are very, very similar if you're interested in that. So we know that well more than half of lung cancers, whether they're squamous, whether they're adeno, rather than small cell, non-small cell, have a direct causative effect or risk factor or promoter or whatever you want to call it from the compounds found in tobacco, specifically we'll call them tars now in cigarette smokes. However, what about all of the cancers? This is the number that most people do not really understand. Not only does smoking, tobacco thing cause more than half of all lung cancers, but almost half of all cancers in general. Okay? I mean, that's astounding. So remember, it's not just cigarettes. So when your patients smoke, don't tell them they're going to get lung cancer. Tell them they're going to get cancer of just about anything. In fact, here we go. This is tobacco smoke. Okay? Now, if you wanted to know the exact carcinogenic, or let's say pro or pre-carcinogenic compounds, you could say one of them is 4-methyl nitrosamino -1 -3 3-pyridyl -1 -butazol, or you could call it NNK. I think I like NNK better. Okay, you know, there's also polonium, the radioactive isotope, in tobacco smoke as well. Now, there's another major tar compound, carcinogen, or what we called before a pro-carcinogen that could be metabolized to something that's even more directly carcinogenic, and that's N'-nitroso-nornicotine. And I bet you thought that nicotine is only the thing that makes you addicted. No, nicotine also is a pro-carcinogen, or this compound of nicotine. So NNK and NNN are the three major compounds. Of course, with lung and larynx, the primary one is NNK. Polonium also has a direct carcinogenic effect as too. And if you wanted to know what to call the tar compounds or NNK in general, you call them polycyclic aromatic hydrocarbons. That covers both NNK and NNN. In cancer of the esophagus, you know, another squamous epithelium, NNN is the primary one. In pancreas, NNK. In bladder, another compound called 4-aminobiphenyl, comma, 2-naphthylamine, also from tobacco smoke. Okay, we're talking about the bladder. And of course, cancer of the oral cavity on the squamous epithelium is both NNK and NNN. And in the oral cavity, not from smoking, but from snuff, it's also NNK and NNN. And we added the polonium in there. So there's a whole bunch of things. The major ones are the polycyclic aromatic hydrocarbons, but also polonium, and even another compound that seems to wreak havoc on the bladder as well. Bladder, pancreas, and esophagus are the three major non-lung or oral cavity areas where tobacco smoke is a carcinogen. Okay, so even though this is kind of a big, ugly compound, I just emphasize the important things in red. So these are relative risks for cancers, okay? Or I'm sorry, all diseases, not just cancers. Now, if you're a smoker, and you're a male, you're 3 times more likely to get cardiovascular disease, atherosclerosis we'll call it, than if you don't smoke. So your risk of cardiovascular disease, specifically coronary heart disease, is 3 times increased. For cerebral vascular disease, you would expect it to be about the same because the blood vessels inside the brain have the same influence as the blood vessels inside your heart. That's also about 3 or 4 times. And there's not much of a difference between male and female, okay? Now, for chronic obstructive lung disease, we'll say emphysema, this is the one that really, a person who smokes, okay, listen to this, folks, whether you're a male or a female, especially females, are about 10 times more likely to develop emphysema than people that don't smoke, okay? Now, when we go to the cancer of various organs, this is the one that'll really blow your mind. If you smoke, and remember, we're talking about not cancers, but squamous, large cell, non-small cell adenocarcinoma, you are over 20 times more likely to get lung cancer than if you don't smoke. Females are a little lucky on that. With females, it's only about, 12 times as much. But look at the other significantly increased organs. They're not just 50% more or 100% more. They're anywhere from 2 to 15% more to get risk likely to get cancer if you're a smoker, for cancer of the lip, esophagus, stomach, blah, blah, blah. And look at even the bladder cancer, even kidney cancer, okay? So these are some really, really rough, horrible statistics. And we have to also talk about the concept of synergy, okay? In other words, if you have a risk of getting a disease, like let's say we're going to show you the relationship between the radioactive gas radon and lung cancer. If that is a certain risk, then if you smoke also, it greatly increases the risk. Okay, here, let's see if we could make this a little bit more understandable. If your risk of getting lung cancer from radon is 1, and your risk from getting lung cancer from cigarettes is 1, then you would think that the combined risk would be 2, wouldn't you? No, it's a lot more. It's synergy. It's what they call exacerbating or intensifying the risk of 1. So cigarettes are synergistic with non-cigarette smoking lung cancer. And of course, we all understand the concept of exacerbation. It's not exactly as horrible sounding as synergy, but if you have bronchitis from any reason, asthma, or some type of lung disease associated with your occupation, maybe you're a coal miner or you breathe dust or fumes or whatever, if you have that association between non-cigarettes and reasons for lung disease, cigarettes exacerbate that, okay? So why would somebody get lung disease? Well, they could have bronchitis from anything, okay? Viruses. They could have asthma, allergies. They could have pneumoconiosis from their disease, or being maybe a coal miner or a welder like my nephew, exposure to silica, coal dust, grain dust, if you're a farmer, pigeon dust, okay? The welding fumes, okay, duh. So if that risk is there, the cigarette smoke's going to exacerbate the effect from this non-cigarette exposure. Pretty fucking, I'm sorry, I shouldn't have used that word. Pretty scary, isn't it? Okay, now, let's talk about probably worldwide. I don't know if I'm going to say it's worse than tobacco, but let's just say it's terrible. And if I sound like I'm giving a lecture or I get excited for the next exposure that we talk about, alcohol, ethyl alcohol, please understand that this is like something that often makes me sound like Sam Kinison, you know, the comedian that would actually go crazy about certain topics. You ready for this, folks? How many people are in the United States? Do you remember the number, like around 300 million nowadays? And this is a few years old. Well, what if I told you that probably more than 5%, maybe approaching 10% of adults are alcoholics? Well, I know what the first thing you're going to say is, well, what's an alcoholic? Okay, now, when we said that tobacco had the effect of about 500,000 premature deaths a year, alcohol is not that bad. So that's the bad news. That's the good news. The amount of economic loss from alcohol is about the same as from tobacco, okay? Now, you may go to conferences, and I have gone to many conferences, and I'm going to use a couple of bad words here, if you don't mind. I've been to several conferences where I heard a doctor stand up and say, oh, did you know that if you take only 1 or 2 drinks a day, it reduces your risk? Well, first of all, it's a fucking lie. And secondly, the guy is probably an asshole. And thirdly, he could very easily be an alcoholic as well. So what kind of person would put this? Even in the medical literature, a drinker, a non-drinker, or an alcoholic in denial. Because if you are going to define alcoholism, and we are pretty soon, we say you cannot define alcoholism without using the word denial. So let's ask yourselves, what's an alcoholic? What is alcoholism? Well, the thing I could tell you is no matter how you define it, if there is somebody called an alcoholic, or, you know, this 5 or 10% of the people in the world, or at least in the United States, the one thing about all of these alcoholics is that they're not going to think that they are, okay? Now, sometimes people would like to define alcoholism by number of drinks. Well, that's baloney too. However, it's such an elusive definition because the people that are obvious alcoholics, you know, including medical people, including people that write in the medical scientific literature, they are in denial. So it's probably one of the most difficult things. And I guarantee you, if you are actually going to a real medical school as well, not just my little pathology medical school, but if you're going to a real medical school, you could sit for 4 years in those classes and you will never have a guy define alcoholism. You're supposed to treat illnesses Well, you could define almost every illness in the world except for alcoholism. However, if you want to make things simple, and I know you do, I can tell you from my personal experience that I have never known anybody that drinks more than 2 drinks every day that I wouldn't absolutely say he's an obvious alcoholic. So if you defined alcoholism as somebody that drinks regularly more than 2 drinks, it's not the best diagnosis because there's so many other facets to it, especially the psychological and social damages that are done, not just things that are done to their liver, but I'll tell you that 2 drinks or more a day, you're either an alcoholic or you're well on your way to it. Now, what's a drink? That's the easy part of what a drink is. A drink is alcohol. Now, whether you have a 12-ounce bottle of beer or a 5-ounce glass of wine or 1.5 or 1.25 shots of alcohol, whether they're straight or they're a mixture, that's a drink. 2 beers, 2 shots, 2 wines. That's what a person would have on a daily basis, one of those 3 or 2 drinks to be regarded, in my opinion, as an alcoholic. Now, have I defined it for you? I don't know. But of course, let's talk about the fact, rather than chronic alcoholism, let's talk about the state of being drunk. And the state of being drunk is measured medically, not by the police, but in a hospital lab as milligrams per deciliter of alcohol. Okay? And even though you're talking about blood level generally here, in terms of police and legal activity, they talk about it as blood alcohol content. And of course, they're directly related, but they're not exactly the same. Anyway, if you have 20 milligrams per DL of alcohol, ethyl alcohol, in your serum, you're going to probably feel it, okay? Now, I'm not going to ask you how many drinks that is, but it's probably at least 1 or 2, okay? You feel a little relaxed. Maybe your inhibitions are a little decreased. Now, if you're up to 80, not only are you still, let's possibly, feeling good, so to speak, but whether you like to admit it or not, you are not going to be performing well, either whatever you have to do, whether you have to drive, whether you have to give lectures. There's going to be a decrease in your complex cognitive functions and motor performances. That's why this number 80 is the magic number, because if you have a blood alcohol content, okay, of whole blood, which is related to milligrams per DL. There's 2 different ways of measuring it. But 80 BAC, blood alcohol content, whether the police does it, whether you have a little thing on your keychain that measure it, you're going to be legally drunk. And if you're caught, probably arrested. And I don't have to tell you what a DUI involves. I don't know what it's like in other countries, but you think a DUI is nothing because people that had 3 or 4 of them, but a DUI is a major, major, major headache in terms of cost and everything. Now, if you're twice as 80, now this is somebody that's an obvious drunk. He got slurred speech, he's got poor judgment, he's got incoordination. This is a guy that you would say is staggering. Okay, now you go 50% above that, or let's say 4% above 4 times 80, and you're actually possibly drifting off into a coma. Now, if you got about 50% more of that, you're dead. So let's just, as a general rule, say a blood alcohol content of 80 is you're legally drunk, whether you admit it or feel it or not. But if you're 5 times that much, you're dead. So that's generally how it works. And basically, now that we know you have alcohol in your blood, okay, what happens to the alcohol? If you remember the chemical structure of alcohol, it's basically, two carbons joined to each other with hydrogens, but one of them is a hydroxyl group. Well, metabolism of ethanol is basically can be talked about as oxidation of ethanol too, because there is a enzyme, a P450 oxidase. It's abbreviated as CTP2E1, whatever it's called. It basically oxidizes the alcohol. Now, how do you oxidize something? Well, you could either add another oxygen or you could take away two hydrogens. It's basically the same effect. Okay, and this occurs in the microsomes of the cells. However, most of it occurs not in the microsomes, but in the cytoplasm or the cytosol, okay? And that basically goes through the NAD to NADH process, taking away a couple of hydrogens, and the result is that you have the same compound, an acetaldehyde. So what does that mean? If you remember from chemistry, if you oxidize an alcohol, put another oxygen or take away two hydrogens, you have an aldehyde, okay? Now, another way to do it is by hyperoxygenating it with, once again, peroxisomes. You remember peroxidase, catalase, basically adds another oxygen as well. But the end result, whether you go through the microsomes, the peroxisomes, or most of it in the cytosol, is you oxidize oxygen to aldehyde. Okay, but now that aldehyde goes to your mitochondria. And if you remember, those are the big oxidizers, right? Because they basically are going to be going through another process of ALDH, or aldehyde dehydrogenase, oxidize it further, ultimately adding another oxygen to give it another O, goes to acetic acid. Now, I know we said a lot about this chart and what it does and where it happens, but basically you go from alcohol to aldehyde to acetic acid, and that's how you metabolize it, okay? Now, this is, I don't know where I got this chart. It's from the Journal of Studies on Alcohol. It's a couple years old, but basically it's not something that would age. These are your blood alcohol percentages. These are the legal values. And if you remember, we have here a number of drinks per blood alcohol percentage. Now, if you only weigh 100 pounds and you have only one drink, you're halfway to being legally intoxicated. If you weigh 240 pounds, which is closer to me, you could have 2 or 3 drinks and 4 or 5 drinks, okay, and still pass the breathalyzer test. So the amount of alcohol in your blood is dependent on your weight, obviously, because it's a concentration thing. Now, but here, I'll show you this. Just about anybody who drinks more than 4 or 5 drinks can probably not pass the police test. Or if you have one of those little things on your keychain that measures your blood alcohol content, also known as blood alcohol percentage, okay? So if you're wondering, and if you're a drinker, and probably a lot of you have drunk or maybe still do, how many drinks does it take to be drunk, or at least legally drunk? Anywhere from, let's say, 2 to 4. Okay, 2 to 5, let's say, depending on mostly your weight. There's a slight difference between males and females, but it's not much. But it's basically 2 to 4 drinks, you're probably drunk. And in other words, 2 to 4 drinks, and you have that magical 8 over there, which measures up as a 0.08% blood alcohol content. Now remember, the police or your little keychain devices measure the concentration in blood. In the laboratory, basically we're measuring the concentration in serum, and it's a little more accurate. But blood alcohol content by volume is the legal measurement, and milligrams per DL in the laboratory is your more precise scientific medical, laboratory measurement. Now there's an equation called the Windmark equation. And this is used in court a lot by professionals who consider themselves experts, like biochemists or whatever. And even though it's a kind of a complicated equation, it's really simple when you look at it. C is basically your concentration of alcohol. And it's a precise laboratory concentration. It's milligrams per DL. It's not this BAC, which you see down here. Wouldn't it be logical that the concentration of alcohol in your blood is directly proportional to the mass of alcohol in grams? Okay, and by a mass you could say the density of alcohol is not quite the same as it is water. So the density of alcohol is a little bit less than water. But here, let's go to the big part of the equation. The concentration of alcohol in you is directly proportional to the amount of alcohol that you took, but divided by your weight. So once again, somebody that weighs twice as much as you do is not going to be only half as drunk. Is going to be only half as drunk if he drinks the same amount. Duh. So body weight is indirectly proportional. Now there's also a little r here, which is a constant, and you can see it's a little bit different for males than females, and that probably doesn't matter, except maybe in court. But you're probably going to say, well, how long do I have to wait after I feel drunk or have so many drinks before I could pass that test or legally drive? And that's what we call the elimination of alcohol based on its metabolism. Remember, we talked about its metabolism. So you could measure that either by the blood alcohol content, which is the legal method, or the milligrams per DL per hour, which is the medical or more scientific method. And the elimination of alcohol is 0.15% per hour. Or if you want to measure it in terms of milligrams per DL, it's 15 milligrams per DL. So whatever your blood level is, an hour later, you've lost 15 milligrams. Now, this is something that I had a hard time understanding at first, but it's called zero-order kinetics. In other words, it doesn't matter what the reactants are, what the alcohol is. It's a constant rate, and it's totally independent of the amount of alcohol or the amount of reactants itself. Okay. And here's a little formula down here at the bottom. You could see it's only a 1 to 1.16% difference between the BAC measurement, the legal measurement, and the laboratory measurement. Okay. You still want to talk about alcohol? Yeah, let's talk about alcohol for a little bit more before I'll break. We talked about it extensively. We talked about the liver and gastrointestinal diseases. Probably besides diabetes and obesity in general, the third category of people to have fat in their liver are alcoholics. Alcohol causes the liver to have fat in it. Okay, so if you take somebody, even that's a binge drinker or a chronic drinker or what you would call an alcoholic by anybody's definition, 90% of them are going to have increased fat in their liver. Okay, now the liver could be significantly enlarged, but is asymptomatic. Okay, so fatty livers or fatty change or fatty metamorphosis is another word, is present in drinkers, especially chronic drinkers or alcoholics. The good news is this goes away if they stop drinking. The bad news is, it's not terribly bad, but when we talked about fat in the liver before, we talked about macrosteatosis, whether the liver globules are bigger than the cells, or microsteatosis, which is the liver globules are inside cells but much smaller than the cell. So when we talk about fatty change in the liver, most of the fat are in globules that are bigger than the cells, or what they call macrosteatosis. So how do you have to document fatty liver? We have to see macrosteatosis in a person that drinks to say that his liver is enlarged due to fat. But he's asymptomatic. He may not have much by way of enzyme elevation. Why? Because there is no necrosis of the liver cells. Once you start to get inflammation and necrosis of the hepatocytes, that's when your enzymes go up. So fatty liver in alcoholics can make it big, but it's asymptomatic, and it usually doesn't rise the enzymes very much. However, and it goes away. But if you stop drinking, but if you don't stop drinking, at least 10 or 15% of the time, that alcohol is now going to acutely damage the liver, what they call alcoholic hepatitis. It's not a viral hepatitis, it's strictly a toxic hepatitis. There is actually swelling of the liver, which means you may have a little jaundice, okay? You're going to have necrosis, and parts of the keratin filaments inside the liver cells kind of coagulate to form these little red inclusions called Mallory bodies. Okay, they're also called alcoholic hyaline. We're going to see a picture of that. So that's what happens if people with fatty livers don't stop drinking. And of course your enzymes are going to go up too. Now, what happens if they still don't stop drinking? So you're going to ask, well, does somebody with alcoholic hepatitis, if they stop drinking, will they still possibly get cirrhosis? The answer is maybe, but there's a good chance no, okay? But if they don't stop drinking, at least half of them will go on to full-blown cirrhosis. This is a irreversible disease, and it has two things. It has scarring. So if that scar shrinks, like most scars do, the liver can become smaller. It may be bigger at first. And rather than having nice hexagonal portal type architecture, it has irregular nodules in which there's no central vein. So here, let's take a look now. Here's why the liver gets fat. Well, first of all, an alcohol actually breaks down the fat, so it brings more fatty acids to the liver, okay? Also, in this situation, you have an increase in NADH versus that NAD ratio, so that stimulates lipid biosynthesis in the liver. Now, if the fatty acids were oxidized, the liver would not have increased fat. But the oxidation of fatty acids by the mitochondria is decreased. And to mix even further, because the cells could be damaged, okay, the microtubules, which transport the lipoproteins from the liver, that's being interfered with too. So there's increased bringing of fatty acids to the liver and increased leaving the lipoproteins from the liver. There are all kinds of reasons why they have fat, and those are the main four biochemical reasons without actually showing you the equations. Here's a fatty liver, and let me ask you a question. Let's say the normal weight of a liver is 1,500 grams, and this liver is twice as big. Let's say this liver was 3,000 grams. Okay. Now, let's say that you know that all of these little big or macro steatosis, these little holes that are bigger than the cells. Let's say that you know that the reason why they're white is because there was fat inside of them, and the fat washes out when you do the histology processing because they pass it through a fat solvent called, it's a fat solvent, okay? So here's the question. If you took all of the fat out of this person's liver, and the liver weighs 3,000 grams, how many grams would be fat? You probably don't know because it sounds like it's a trick question, but look, if you take a look at this section of the liver, probably over 50% of the cross-sectional area are these big holes. So you could say this person, if his liver was 3,000 grams, probably more than half of that would be fat if you extracted all of it, okay? Here's some more fat, okay? And once again, you'd have to have macrovesicular fat, which means these bigger lobules, rather than just microvesicular fat, which are these tiny ones within the cells themselves. That's one of the criteria for fatty liver. So when you see a fatty liver in an alcoholic, or probably anybody, there's probably a good amount of vacuoles that are bigger than the actual liver tissue. Now what do you have here? Well, you have some more fat. And I have a little inset here, so this is not part of it. This is another picture, okay? But in this liver, you have fat, but you also have inflammatory cells, like here, and here, and here. And look at these hepatocytes. They're damaged. They're necrotic. And in addition, if you look carefully, there's a little red thing here inside of a cell. There's a little red thing here inside of a cell. There's a little red thing here. And you know, these are the things we call Mallory bodies. They're also called alcoholic hyaline. And if you look, I was looking even more carefully. Probably in this field, if you look carefully, you could find about 10 of them. And up here, you could see at least one high power. And this is probably a nucleus of a necrotic cell or a degenerating nucleus, and that's possibly one over there. So, inflammation, fat, and Mallory bodies. That's alcoholic hepatitis. And I don't think I have to tell you what this is because we dealt with this extensively. This is a liver, and you could see that's a nodule within a liver, and these nodules are separated by fibrous tissue, and some of the nodules are bigger than others, and sometimes there's some inflammation going on. So even though there's a lot of adjectives for cirrhosis, you know, cardiac cirrhosis, Laennec cirrhosis, nutritional cirrhosis, alcoholic cirrhosis, macronodular cirrhosis, this is cirrhosis, period. Now, in alcoholic cirrhosis, the nodules are usually fairly small, not much bigger than the original portal areas or portal lobules. So most of the liver cirrhosis is micronodular cirrhosis. You know what? We've been doing pretty good, and I would normally continue on this alcoholic topic, but let's take a break now because I'm looking at the clock. It's an hour. And I don't think it's fair to keep you sitting there for more than an hour straight. So let's take about 3 music songs here and drop this down and say goodbye to our little seagull friend. This is one of the guys I feed every day down at the lake. And let's go back up to our view of my crazy critters that are on the wall. And we'll play 3 more break songs. And here they are. every song that we have today will be by the Eagles. If somebody was to ask me, what's your favorite classic rock group? Probably Eagles might be the first thing that comes to my mind, but there's a few other ones that are very, very high on the list. At this stage, you've probably been asking yourself, hey, this was supposed to be on exposures. Why are you spending half of your time just on alcohol alone as an exposure? We understand, okay? We talked about it when we talked about cirrhosis. Why alcohol is being half of our time today? Well, I want to give you an amazing fact, and you probably won't believe it at first until you think about it. And I didn't mention this before. You know, alcohol has such a tremendous impact on any physician's practice. A part of every history is whether the patient drank, smoked, okay? But here's one that's astounding. I told you, and I hope you believe it, that no matter where you're from, probably between 5 and 10% of the people that you know are alcoholics, okay? By whatever definition you choose. In fact, I challenged you to ask yourself, do you know anybody that drinks more than 2 drinks a day and probably might not qualify for alcoholic or early alcoholic? But here's the most astounding. We haven't really talked about the social aspect, devastating social aspect of alcoholism, the damage it does to families. So I'm going to give you a statistic. Let's say that you have a mother, a father, brothers and sisters, a wife or a husband, and children. Well, how many people did I just rattle off? Like about 10 or something like that? You are even very, very close friends. And you believe that between 5 and 10% of them probably qualify as alcoholic. So my question to you is, there is a 50% chance that no matter who you are, no matter where you are, your life has been very seriously harmed. I'm not going to say devastated, but it could be, by a close relative or even close friend in your family that has alcoholism. So that makes alcoholism contagious, doesn't it? I normally don't say this during a webinar, but that was also true in my family. I spent a lot of time in Al-Anon, which is a support groups for family members of alcoholics. And for me, it was a big, 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 big success. Okay, let's continue now, and we'll close this guy over here, and we'll pop up the PowerPoint again and say a little bit more about alcohol before we go into some of the other exposures. Okay? Central nervous system. We talked about cancers. Okay, we talked about cirrhosis. Let's talk about brain. There are 2 syndromes associated with alcoholism. Technically, it's kind of combined into one now, but historically, there was Wernicke's syndrome, and then there was the more severe Korsakoff syndrome. Now we realize it's part of a spectrum, and Wernicke's syndrome was primarily due to nutritional or vitamin B1 deficiency, okay? And Korsakoff syndrome was more of a direct toxic effect. So this one did not have a high mortality rate. This one was often fatal, okay? So in Wernicke's syndrome, we have confusion, ataxia, not just as an acute drunk, but somebody all the time. Diplopia, double vision, ophthalmoplegia. Well, what are the parts of the brain that might be involved in this? Well, classically speaking, the damage in thiamine or vitamin B1 deficiency, so the mammillary bodies, maybe some to the cerebellum for the ataxia, and the periaqueductal gray matter of the midbrain. If you remember, we have the cerebral aqueduct, and then around it there's gray matter, or gray matter means cells or nuclei. So there's a couple of nuclei there around the aqueduct. One of them is called the red nucleus. The others are the oculomotor nuclei. And these are the things that can produce the symptoms, usually non-lethal, of Wernicke. cessation of drinking and vitamin supplements, okay, getting that thiamine back into the diet is the main treatment. And Korsakoff syndrome, the evil end of the spectrum, is a little bit more severe. It could be memory loss. It could be confabulation, okay? Basically, it's like some of your professors that you know don't know what the hell they're talking about. And it could also be from thiamine deficiency, but also direct toxicity. Here's a nice midbrain. Here are the aqueduct that you see through here. And here's some hemorrhage or damage to the periaqueductal gray matter. Okay. Here, mammillary bodies, part of the limbic system. Okay, if you remember that, involved in a lot of things. So the things that we talked about, for example, confusion, ataxia, eye problems, ophthalmoplegia. Okay, this can also always be primarily from the areas that we talked about. Here's a nice picture of the base of the brain down here. And I'm going to show you a mammillary body nicely colored in orange over there. Or if you did a coronal section, you could see the mammillary bodies here are basically a very hemorrhagic, or we'll say damaged. We talked about liver. We talked about nervous system. We talked about the effect of alcohol or cigarettes on the cardiovascular system. But one of the most common forms of cardiomyopathy, which we talked about already in the chapter on heart, was directly due to alcohol toxicity. I had a close friend that had a cardiomyopathy, and actually it was not from alcohol. Do you know he had about 7 or 8 medical students come into his room every day and ask him how much did he drink? I mean, that's how common it is. So basically, there's 2 most common types of cardiomyopathy are alcohol, maybe at the top of the list, and also a viral or even a genetic cardiomyopathy. Also, alcohol on the cardiovascular system can be related or cause hypertension. Why? Because it's a vasopressor pharmacologically. That's why. Want to go into the gastrointestinal tract, gastritis, pancreatitis. The prime stimulus for most of pancreatitis is a binge, a bout of heavy drinking due to direct toxicity. Same thing with gastritis, okay? You can have a disease in which the muscle is damaged, lysed, rhabdomyolysis, also because of alcohol toxicity. It could result in testicular atrophy, and the reason for that is a question mark. But if you remember that in cirrhosis and liver damage in males, there is a predominance or a preponderance of estrogens relative to their androgens. So that could be an explanation. But also in women, high rate of miscarriages. In the fetus, it could be a fetal alcohol syndrome, also due to direct intrauterine toxicity, where there's growth retardation, mental retardation, and a whole wide variety of increased birth defects. Okay, let's talk about regular drugs. Let's talk about the 4 most common types of drugs out of millions, and of course, nowhere near to what you'll learn about this in pharmacology, but let's single out birth control pills, a higher dose of estrogen, hormone replacement therapy, acetaminophen or Tylenol, another non-steroidal drug, but the classical one, aspirin, probably has done more damage than all the rest of these put together. In other words, non-specific cyclooxygenase inhibitors or non-steroidal, the classical non-steroidal anti-inflammatory drug used for zillions of years and probably still is. Okay, woman goes on birth control pills. She wants to know if it's going to increase her risk of breast cancer, because breast cancer is related to breast growth, estrogens. And the good news is, no, there's no significant correlation with regular modern birth control pills and increase breast cancer, okay? In fact, I'll give you some more good news. There's actually some statistical decrease in endometrial and ovarian cancers. And you know, endometrial cancer is one of the risk factors is estrogens as well. So it's basically low-dose birth control pill. Don't worry about breast cancer. Don't worry about endometrial cancer being increased. Don't worry about ovarian cancer. However, now that you're on birth control pills, you could probably have more of a great time than you did before because you don't have to worry about getting pregnant. So statistically, again, because of the increased sexual activity, probably, that's why they put a question mark there, could be due to lifestyle change because of now you got more freedom if you're a woman. Now, in terms of thromboembolic events, however, am I going to get blood clots? Well, the answer is there is a statistical increase in blood clots, including pulmonary, the clots that go to the lung, the pulmonary emboli, okay? Also, there is a very common genetic condition called factor V Leiden mutation, which basically causes a propensity towards blood clotting. Well, that kind of increases the risk as well. So you can say, don't worry about cancer, but there is some question about blood clots. Now, if you remember, we said when we talked about atherosclerosis that the reason why women get their heart attacks 10 years later than men, let's say as a general statement, that estrogens have always been regarded as being kind of cardioprotective for atherosclerosis. However, there is some increased risk of cardiovascular disease, especially with clotting, not just strokes, but myocardial infarction as well. Okay? There are primary benign liver tumors that often look like cirrhosis because that's kind of a nodular adenoma in the liver, but they don't have all the criteria. There's no risk factors for cirrhosis. But I've seen a couple of patients with benign hepatic adenomas. And the bad news is they are all associated. I hate to use the word all, but every one that I've seen is associated with like long-term BCP usage. So don't worry about cancer, but there is some statistical correlation with clotting, and it is the primary risk factor for these benign hepatic adenomas. Now, what about hormone replacement therapy? Now we're talking about higher levels of estrogens, okay? So the women don't age and maybe go through menopause not so roughly. Well, there is an increase of breast cancer here. It's basically a higher dose. And technically, the people who have been on the therapy for 5 years are the ones that have the most statistical risk to a breast cancer, because now, like all of the other breast cancer, you're being exposed to estrogens for a longer period of times. And the same problem now, we have about a twofold increase in thromboembolic events, and also because of that, a statistical increase with myocardial infarction as well. So think of all of the bad things estrogens could do as being not quite as bad with birth control pills, but definitely more with the higher estrogen level and hormone replacement therapy. Tylenol, maybe number one analgesic, okay? Technically, it doesn't have quite the anti-inflammatory effect, but it's very good for fevers. It's very good for pain, and it's one of the most common things you might give a kid. The big thing, especially the higher dosages of Tylenol or acetaminophen, have been associated with hepatic necrosis. So take a look at this liver. Do you see there's areas in here that are hemorrhagic and vacuolated in here, in here? Do you also notice that these little necrotic areas, and I'll point them out again, like here, here, here. Do you notice they're not really in close proximity to the portal areas? It's what they call a centrolobular necrosis. Now, the kind of ironic thing is that technically most of the toxic damage to the liver is usually or very often in the portal area because it's closer to the blood supply. But the ischemic problems, like with the heart failure, is in the central vein because it receives less direct blood than in the portal areas. But there are certain drugs like Tylenol, which when they cause damage to the heart, as an exception to the rule, damage to the lung, do it as a central lobular necrosis. Whoops. You think we could put that guy back? Yeah. So here's basically some guidelines. You shouldn't exceed more than about 4 grams per day because, like with aspirin, if it's not working, you're going to make the crease bigger and bigger. And the toxic dose, at least in adults, is 15 to 25 grams. Okay, now let's get to the biggie. Let's talk about aspirin. Believe it or not, people have intentionally overdosed on aspirin, as well as taking a whole bunch of it, thinking if they have a terrible pain, they need massive amounts of aspirin. Well, that results in a very serious and sometimes fatal condition in which there is a respiratory alkalosis, which can be followed by even a worse metabolic acidosis. It could be fatal. Now, people that are on higher doses of aspirin develop this syndrome called salicylism. And even though you may have heard that ringing of the ears or tinnitus is one of the main symptoms, they get dizzy, they get headaches, they get confused, and that's also another sign of aspirin toxicity. And of course, all of your drug reps will tell you that you shouldn't use aspirin, which costs basically a penny a pill. You should use their COX-specific agents, which only suppress cyclooxygenase 2 rather than cyclooxygenase 1, because aspirin, in its suppression or inhibition of cyclooxygenases, inhibits the cyclooxygenases that are involved with platelet stickiness and also gastric mucosal protectiveness. That's why patients with aspirin have increased bleeding, and they also have increased bleeding, especially in the gastric area, and there are actually still now, I don't have the statistics, but many patients a year, at least in the non-specific days or the cheap aspirin days, were dying because of GI bleeding due to long-term aspirin therapy, like patients with rheumatoid arthritis. Okay, there's another syndrome called Ray's syndrome. It's a fatty liver and it has an encephalopathy. It's mostly in kids under 15, and that has been linked strongly to aspirin therapy as well. Okay, I know you're probably going to get this ad nauseum with pharmacology, but cyclooxygenase inhibition of COX-1 is bad because it screws up the platelets in the gastric mucosa. Aspirin keeps platelets from sticking to each other, and it also loses the gastroprotectiveness by synthesizing prostaglandins if you inhibit COX-1. Now, if you inhibit COX-2, that's good, because basically that's the anti-inflammatory thing. And basically, aspirin inhibits both, but the so-called selective NSAIDs inhibit only COX-2. I'm going to give you a chart here, and I know you're going to freak out like I usually do when I see it, but basically all these prostaglandins are heavily involved with cyclooxygenases, and if you regard arachidonic acid as your main eicosanoid, basically gotten from the breakdown of phospholipids in the cell membrane, You then have several directions that you could go to. Basically, they all involve cyclooxygenases. One of them is in the leukotriene lipoxygenase, lipoxin, and the leukotrienes basically neutralize or do the opposite of what the lipoxins do. And of course, now you have the prostaglandins and your thromboxanes as well. So I'm not going to go to any further than that because it's better to just understand that all of these so-called icosanoid products are significantly interfered with either as cyclooxygenase 1, cyclooxygenase 2, or both of them. Couple of final words. We'll say a couple words about maybe some of the main agents here of indoor air pollution. Technically, carbon monoxide, obviously, nitrogen dioxide from acid rain, people that cook or inside with wood smoke, formaldehyde, okay, is indoor air pollution. I don't know too many pathologists that are freaked out by it, but basically, when you walk into a pathology lab, and you have for many years, you'll not want to think that it could be a toxic or exposure, but it is. So we're basically going to be talking just about radon, but remember the so-called bioaerosols or your mineral fibers like asbestos. These are all indoor air pollution. We're going to say a couple of words about radon, however. And it's a radioactive gas. Okay, it's ultimately from the decay product of uranium, which is naturally occurring. So it's widely distributed in the soil, just where uranium might be. Okay, and because it's heavy, it usually concentrates in the basements. But it's an alpha emitter, which is a heavy particle. So these alpha emitters, technically in your basement, can cause mutations as radiation, and they are associated with an increased rate of lung cancer statistically. Not nearly as much as cigarettes, but they can. However, cigarette smoking considerably increasing that risk. So if you're in an area where you're concerned about radon, basically the result is to ventilate that basement, make sure that that air, that heavy particle radon gas basically doesn't just hang around. And the last thing we'll talk about is lead as a heavy metal and as probably the most significant toxic exposure of all the heavy metals. Lead's around everywhere. It is in the paint in older homes. It's in the plumbing in older homes. It's in lead glazed ceramics, and it's in industrial exposure. So people that have a problem with potential lead exposure can either be exposed to the lead itself or the manufacturing of lead. Now, if you are exposed to the lead itself, it's usually an ingestion. Okay, so technically the scenario where kids that used to eat or pick at the lead like they might, or people with certain illnesses that love to eat things like dirt and stuff like that, that was a source of lead. But in the people involved in the manufacturing of lead, like ceramics or industry, they were basically got their lead exposure through inhalation. Okay, now lead, your body thinks that lead might be calcium because it's a divalent cation. Okay, so it's taken up by the teeth in children. And we're not talking about a radioactive half-life. We're talking about a non-radioactive half-life. The lead that you or kids have in their bone, not radioactive lead, regular lead, stable lead, half of it is still going to be there in 30 years. So lead hangs around. Now, even though you can have increased lead in your blood, it's usually rapidly cleared by the blood, okay? But if you do have a lead level in your blood, it means there's probably been a recent exposure because that's just pretty rapidly cleared, and it goes where lead goes. It goes where calcium goes. It goes into bone, and also it goes technically into nerve processes as well. Now, technically, you cannot tell what the body lead level is just by doing the a serum test, because it's usually gone unless there's a very recent exposure. So most of it is distributed in where calcium goes, as well as soft tissues. And the excretion of it technically would be kidneys, but it hangs around for a long time. Biochemically, it interferes with the synthesis of heme in the heme part of hemoglobin, and it results in clinically or in the laboratory is what they call basophilic stippling of the erythrocytes. So here's some erythrocytes, and here's some blue stippled areas. They're actually ribosomes, and that's due to lead, the fact that lead has an affinity for the enzymes that make the heme. Okay, how about if we talk about the fact that your body thinks lead is calcium because they're both divalent cations, okay? And where does calcium go? Well, it goes into the bone, so does lead. And also, calcium is involved in nerve and brain transmission, so the excess of lead could result in nerve and brain problems, and specifically, these are usually demyelinating type processes, okay? And let's take a look at some of the pictures now. This is probably a good general diagram of the potential effects of lead exposure or increased lead exposure. Well, we know it could cause basophilic stippling and anemia because of its damage to the erythrocyte ribosomes. We know it could do damage to peripheral nerves. Why? Because peripheral nerves are heavily myelinated, and it's a demyelinating substance, which is nonspecific, but it still causes demyelination in the brain as well as in nerves. Now, clinically, one interesting thing to see, it also causes a little bit of a hyperpigmented line between your tooth and your gingiva. That's called a lead line, and it could be seen clinically. But there's another type of line called a bone line, which is seen radiologically in the distal metaphyses of the bone, okay? Now, if you're a kid and you're eating lead for whatever reason, ingested, a lot of times you can see the little lead particles within the gastrointestinal system as well. And it can also cause an interstitial disease in the kidneys as well. So these are all the things to remember. If you are a spray painting or doing foundry work or at the mining and extracting lead level, battery burning, these are occupational inhalation sources of lead. But if it's in the water supply because of the pipes, or in paint dust or flakes, dust in the house, soil, newsprint, I don't know how much of a problem that is anymore. Or remember, leaded gas. These are basically non-occupational, usually ingested type of exposures. Here's your basophilic stippling of red cells. Here's one that is not quite as subtle. Not quite as obvious as these. In this one, it just looks like the red cell is a little bit bigger than usual. A lead line could be this slightly hyperpigmented area between the gum or the gingiva and the tooth. But a lead line to a radiologist are these increased densities within the metaphysis, okay? Here's the epiphysis and here's the distal metaphysis, and those are lead lines, okay? And finally, if the lead involved a major nerve, for example, like a radial nerve, you might get a radial nerve palsy, which of course is also called wrist drop, because the radial nerve extends the wrist, okay? If you are a radiologist and there's been suspicion of an ingestion, you might see these little dense things within the intestines. If you are a child or an adult with an exposure and you have not just nerve conduction problems like you would see here with these nerves being demyelinated, you can also perhaps see demyelination within the brain as well. And take a look at this last picture, which I just found yesterday for the first time. It looks like it's basically periventricular, and you might think that maybe this patient has multiple sclerosis because it's primarily or largely in the periventricular white matter. But this is the edema in the MRI that goes hand in hand with demyelination. Okay, we're done. And we've in the next or last webinar this week, we're going to talk about a few other exposures, like radiation exposures. And it's not going to be a very long webinar on Thursday. Maybe you'll be glad to know that. But we will end our webinar today. Let's see if we could put the ugly guy back up there. Yeah, we're going to end our webinar today with my single favorite song by the Eagles, and it's called Desperado. And sometimes, even though we like to think positively and that we're doing good things, and we have done good things, sometimes you could just feel like life or your own life is a little bit desperate. I don't know, maybe these past couple of years with all of this crazy stuff going on in the world, you might have felt like a desperado. So maybe that's what the Eagles had in mind when they made this my favorite Eagles song. favorite rock songs, and this is my favorite rock song from my favorite group. So I would recommend, as I think it was Glenn Fry that was singing this, "Let Somebody Love You Before It's Too Late," and that way you could continue to rock on.